Yeah, good afternoon. So I'll be more practical actually. I'll just show you pictures and I want you to be more proactive and tell me what you will do when I'll show you pictures. So there is a lot of, because prolactinoma, we say that at least it is now the domain of endocrinologists. PCO, obesity, diabetes go to almost all kind of fraternity, but prolactinoma once you have, the patient will at least visit you once. So we have quite a lot of experience and you will be surprised that my DM thesis was on prolactinoma itself way back in 2011 when we published this in clinical endocrinology. So we know that it's sometimes people say that it's easy to treat prolactinoma, but it might not be, because we know dopamine agonists are the treatment of choice, and amongst dopamine agonists, this cabergoline is the treatment of choice for prolactinomas. But I will just take you to a journey of different things. This is the institute from where I come, PGI Chandigarh. This is the gate through which I enter daily, and we go to a class at 8 a.m. and it is a fixed class that we do for all our students. So few facts about prolactinoma. It is the most common hormone secreting tumor of the pituitary. 40% of all pituitary tumors will be prolactinomas, and we know that microprolactinoma is much more common than macroprolactinoma, and we see day in and day out many people coming with prolactin of 60, 70, and somebody did MRI and found out a 2 mm lesion. So will you say this is a prolactinoma or it is just a adrenal or pituitary incidentuloma or pitnet that you call? So that is the semantics, but definitely if it is hyperprolactinemia you need to treat with cabergoline. Female preponderance, and what we say that males usually have macroprolactinoma, which is much more common, because males may not have features of hormone dysfunction, because females come early because of menstrual irregularities. And giant prolactinoma, we say that when tumor on any dimension, whether it is AP, whether it is the height is more than 4 centimeters. So whenever we see a case of prolactinoma, what is our aim? First is patient should be asymptomatic for what the patient has come to you. Now for a female it can be because of menstrual disturbance, it can be because of infertility, can be because of galactorrhea, but for a male it mainly because of mass effect, that they can have some visual disturbances or a headache, but they might also have erectile dysfunction. So first aim is normalization of prolactin. Second aim is the tumor. Now the mass effect of the tumor, which is in the cellular, supracellular region or the paracellular, which we grade by NOSP grading. Then third aim is, after you have achieved normal prolactin and the tumor is absent, you should have normal function of other cell lines which are in the pituitary. That is most important will be gonal trough function. So normal gonal trough function would be there, and whatever you choose to treat, the patient should have sustained remission. So we forget that even for prolactinoma, the remission rates are very poor despite having normal prolactin and absence of tumor, and I will show you some data related to that. So the question is how these 4 aims in prolactinoma can be achieved with this patient. Now we know that for all other pituitary tumors, whether it is acromegaly, Cushing's, non-functioning pituitary tumors, surgery is a treatment of choice. Why not prolactinoma should be treated surgically? And you will be surprised that now we have a lot of papers coming from China and published in Frontiers. What they say that in the era of endoscopic transnasal surgery, prolactinoma is also a disease of pituitary surgeons and not of endocrinologists. And why they are saying that, I will show you in the future slides. But at present, even the Endocrine Society guidelines say that dopamine agonists are the treatment of choice for prolactinoma. So prolactinomas are exception. So why they are exceptions? Because we have a drug that selectively affects only one cell line, and that is lactotrophs. So D2 agonists are very selective. Therefore, you can choose a drug. It will not affect thyrotrophs or gonadotrophes or corticotrophs. Effect usually occurs within hours. Suppose a patient is coming with some visual field defect because of prolactinoma, and you give cabergoline to a patient. You will be surprised that visual field functions improve within 24 to 48 hours, and that was my thesis in DM. So what we did visual fields almost 12 hourly in a patient who was given cabergoline. We also did this the prolactin levels in these patients every 72 hours and then weekly in these patients, and we wanted to know how early these prolactin levels comes down once you give a single dose of cabergoline. Cabergoline we know is a weekly dose, and sometimes it can be given even twice weekly. So D2 agonists have a very rapid effect. They are safe. They lead to normalization of prolactin in almost 90% of patients, sometimes 100% if it is microadenoma or an idiopathic hyperprolactinemia. More than 50% tumor shrinkage can be seen in almost 2/3 to 3/4 of patients with prolactinoma, and scope of recovery of other pituitary functions, because you can have a compressive effect because of the tumor. Now once the tumor is shrinking, this drug which is very selective for lactotrophs, you can expect that thyrotroph or corticotrophs or gonadotroph will now function. So this is the thing, and then you can successively withdraw this therapy after you have treated this patient. So just telling you a few examples that we see, you can see this is a huge tumor, both paracellular and supracellular extension reaching up till even the third ventricle. So before D2 agonist, this patient was one of the patient in my thesis, and then after D2 agonist, you can see what you see here. Actually, I don't know, I have a pointer here. Here, what do you see here? Do we have a pointer, please? I have. You can see a huge tumor, and after therapy, what is here? Empty cell. So this is the beauty of this drug. So you can have such large tumor and every pituitary surgeon will jump over it. I'll operate. Patient coming with severe headache, visual field defects, short of optic atrophy. We gave D2 agonist and everything was fine, though the patient was definitely required thyroid hormone as well as Hysone for long time, because patient was then pan-hypopet. But you can expect patient will be free of tumor. So D2 agonists are very useful. The question then comes is which D2 agonist? We have bromocriptine, we have cabergoline. So both of these are there, and I have also compared pergolide in this. So this table I made just to show you what is the difference between all D2 agonists, and you can see cabergoline is the most potent D2 agonist to normalize prolactin levels. Almost 100%, because most of these in this series by Molich and Colau, they had microprolactinemia and idiopathic hyperprolactinemia, as compared to only 66% with bromocriptine. So now nobody uses bromocriptine. So we know that this is very effective. Now cabergoline is the best choice D2 agonist, and it is now also recommended by the Endocrine Society guidelines published in 2019. This is related to the tumor size, and we also had a good amount of data that we published in Clinical Endocrinology, and we found out that 94.7% tumor reduction in more than 50%, 94.7% tumors had more than 50% reduction with cabergoline, that was in my thesis. But all of the authors from, mainly these are European studies from Italy and Spain, and what they found out that you can expect a good amount of tumor reduction. Some have taken 30%, some have taken 25%, some have taken 50%, but you can expect 70 to 80% of the tumors will have 30 to 50% reduction, maybe within next 12 months to 24 months. So this is the tumor outcome in patient with macroprolactinoma. So this is specifically for macroprolactinoma. Now how do you start treatment? So one thing is sure, cabergoline is the treatment of choice. We usually start with a low dose of 0.5 milligram weekly, and on the basis of response to therapy, and we monitor it by prolactin levels. So if I ask you, when do you think that prolactin levels should normalize, or what is the rate of fall of prolactin after cabergoline therapy in patient with prolactinoma? Any answers? How should it fall? Suppose I do prolactin level, somebody is coming with prolactin of 10,000, what would be the prolactin after 1 week? Just a wild guess, 50%. So I will show you data, you will be surprised, more than 90% fall in dopamine sensitive tumors with cabergoline. So almost in my thesis, almost all my patients who were dopamine sensitive, they had more than 90% reduction in the prolactin levels within a week. So this is the beauty of this drug, and that's why you can titrate your cabergoline therapy by prolactin levels. You expect more than 50%, as somebody said, by the end of 4 weeks, because this can be a marker of dopamine agonist resistance, and we will discuss about that in future. So usually it is increased every 4 to 8 weekly, and maximum dose is 3.5 milligram, which we usually reach by maybe around 4 to 5 months, but why to wait? So, this is a strategy of treatment to fail or treat to fail approach, like we do for diabetes. You add a drug, wait it to fail, then you add another drug, wait it to fail. So, why not to start with a combination therapy? For diabetes I am telling, but for here again, if somebody is coming with a large tumor and somebody is having a prolactin very high, why not to start with a higher doses possibly. So, we worked over that also and I will show you. So, problem is normal prolactin is seen in 95%, but not all. Tumor remission, that means complete disappearance of tumor from the cell in almost only 2/3 of patient, not all. So, that is a trouble with D2 agonist therapy still. So, what you can do for these patients, that we will discuss. So, these are some strategies that you can do. One, these outcomes can be improved either by giving higher doses than 3 milligram, that is the usual dose when we hike the doses of cabergoline. Second, instead of hiking the dose every 8 weekly to 12 weeks, after 12 weeks, why not to start hiking the dose quite early, maybe every weekly, so as to achieve a higher concentration, so that it can help in normalization of tumor. Third, can we continue D2 agonist for a longer duration than usually recommended? So, can it lead to earlier normalization of prolactin and in greater tumor reduction? So, do we have evidence for these 3 questions that I generated, and there are a lot of evidence for that, including our study. So, I will show the first strategy is why not to have higher doses than 3 milligram. So, this was a beautiful paper from Japan published by Ono, published in JCM in 2012, what I remember. Actually, I remember these papers because when I was writing my dissertation, so I cited all these papers. So, they gave a dose of 12 milligram and they could achieve 100% normalization of prolactin and tumor reduction in almost all the patients. So, they gave, this is one of the first paper that showed that even higher doses than 3 milligram can lead to normalization of prolactin in almost 100% of patients without any adverse event. So, this is the thing. So, cabergoline dose range from 0.5 to 12 milligram per week in this Japanese paper. So, that suggests that if you are having some suspecting resistance and your prolactin has not normalized, with a 3 milligram dose, do not shy in increasing the dose to 4, 5, 6 and 7. We usually do it. And in Europeans were very critical of this paper. They have now come on to 7 milligram per week. Even if you talk to Anna Maria Colau, who was there in Trendos last week, so she was also saying that you can have 7 milligram per week dose in these patients. So, this is our paper that came out of my thesis. That was a comparison between intensive and conventional cabergoline treatment of newly diagnosed patient with macroprolactinoma. So, we had a hypothesis that if you can saturate the D2 receptors early by a rapid titration of doses of cabergoline, can you achieve an earlier normalization of prolactin and can you achieve the more tumor remission in these patients. So, this was based upon the receptor fractional occupancy concept that we read in pharmacology textbooks. So, what we did is, you can see the prolactin levels from 7,000 reached almost around 500 or 600, almost 90% fall within first 2 weeks. This shows that they are D2 responsive tumors. So, prolactin is a very good thing to be monitored every weekly if you can, because that can help your patient to understand that whatever the doctor has given is working. So, this is how the prolactin falls. So, this is one of the outcome of our paper, and then it gradually reaches to the normal levels when we followed these patients for 72 weeks in this study. This is the tumor reduction, and you can see that you can expect tumor reduction, almost 60% tumor reduction by 12 weeks in your patient. So, in my thesis I did MRI for weekly in our patients, and you can expect almost 40% reduction by 4 weeks, 50% reduction by 8 weeks and almost 60% reduction by 12 weeks. So, it was a very intensive protocol that we followed to understand the basics of prolactinoma. So, that means weekly hike therapy in few of your patients can work for normalization of prolactin. So, two kind of strategies might work in few of your patients. If you are thinking that your 3 milligram dose is not working, or every 3 monthly hike dose is not working. The next question comes when you have started cabergoline, How long? And that's the patient asks. How long to continue D2 agonist? Again there is a controversy. Endocrine Society says that you should have a normalization of prolactin and there should be complete absence of tumor in the MRI, and patient should be on cabergoline therapy for over 2 years. So this is an indication at which now you can take a decision to stop cabergoline therapy. But I don't know how many of the patients could achieve this, because in macroprolactinoma we have burned our hands. Hardly 30% of patients have complete absence of tumor. Some residue is still there. They will have prolactin hovering around our ranges till 25 in female and 20 in male. So their prolactin would be 30, 35. Now in 35 prolactin patient is eumenoric, you will do another test. What is that test? Eumenoric woman after treatment with cabergoline, prolactin is 35 for next 6 months. What is the test you would like to do? Macroprolactin. Why? Because patient is asymptomatic. Prolactin is still 35, 30. That means something is wrong. So we do pegylated separation of prolactin and we do macroprolactin. And if macroprolactin contribution is less than 10%, you will attribute it to prolactinoma itself. So this is how we work. But problem is, these patients, I don't know why they don't achieve remission. Like in grave disease, we say hardly 30% goes into sustained remission. So this is the ESI Endocrine Society recommendations, and there is a lot of caveats to this stoppage of D2 agonist therapy, because many of these patients have recurrence of tumors and recurrence of hyperprolactinemia, and it is as high as 26 to 69%. Even we forget that this is a disease that you can have recurrence and you can have the problems. So after cabergoline withdrawal, these patients can have biochemical recurrence, and lot of papers have come up related to that, and almost all these papers say that recurrence even after treatment duration of 24 to maybe 12 months, the recurrence rate can be as high as 30%. So this is the normoprolactinemia after cabergoline withdrawal. So you can just, I was telling you Endocrine Society guidelines, suppose your patient satisfies both of the criteria. Tumor is absent, prolactin is normal for at least 1 year, and then you stop cabergoline therapy. But even after that, 1/3 of patients will have recurrence. So please follow your patients after stoppage of cabergoline therapy to see for prolactin levels, and it should be checked at least 12 weekly after stoppage of cabergoline. Because if somebody who has normal prolactin for 12 months with absence of tumor and you stop cabergoline and he has recurrence of hyperprolactinemia after 12 weeks, that is a marker that this patient is unlikely to go into sustained remission for quite long. And I will not shy in saying here that these patients might require lifelong cabergoline therapy. So this is a trouble. They have also found out in this paper by Anamara Kulau that if you are having even a small remnant of tumor, the recurrence rate are very high, and recurrence rate are as high as 19 to 20% per millimeter residua of tumor. Your radiologist might not detect a tumor in the MRI. They will say no, everything is normal, the tumor is gone. But still you can have a small amount of residua, and that is causing recurrence of hyperprolactinemia after stoppage of cabergoline. So this is the thing that people say in most of the European papers. They say that it is the prolactin that comes and it is not the tumor that recurs. But is it true? So I will show you one of the example that we published, that tumor can also recur after stoppage of cabergoline therapy. So this is a patient that was again in my thesis in 2010-11. He came with actually subclinical apoplexy. You can see apoplexy. So this was a huge tumor, both paracellular and cellular tumor. We treated him with cabergoline. He had some kind of subclinical apoplexy. After some time, everything was fine. He had an empty cella. His prolactin was normal. After 3 years of therapy, he satisfied all Endocrine Society guideline recommendations to stop cabergoline. Prolactin was normal for 2 years, absence of tumor. I was happy. I stopped the cabergoline therapy. And you will be surprised, after 10 years, he landed again in PGI emergency with headache and apoplexy. And I will show you the image. So this was in 2023. Fortunately, I was in PGI again, stuck up in PGI, and I can see this kind of tumor. You can see nothing is here, and again 10 years after that he again had a tumor. So should I be blamed for that? Had I missed something? Maybe not, maybe yes, I don't know. But that tells us that we need to be cautious and we need to follow our patients whenever we see a patient of prolactin. So that we just published at macroprolactinoma and empty cell, swinging pendulum and lessons for dopamine agonist therapy. Okay, let's move forward. So what predicts recurrence? When I am saying that 1/3 of patients can have recurrence, what actually predicts it? Does the prolactin level at diagnosis predict it? No. Prolactin levels can be 50,000, can be 500, it does not matter. Does tumor size predict it at baseline? 5 mm tumor versus 40 mm tumor? It does not. Recurrences are most likely seen in the year after withdrawal, and it depends upon the duration of cabergoline therapy. Longer the duration of cabergoline therapy, less likely is the recurrence. So that's why now the Endocrine Society guidelines say even after, suppose I start cabergoline today for a microprolactinoma, patient achieves all the two guidelines that tumor is absent, prolactin normal just within 3 months. What will you like to do? Will you like to stop? I have achieved both the things. The guidelines say that you have to continue for next 1.5 years till 2 years of therapy, and that comes from recurrence data. So that is very important. And I have already told that recurrence rate is 18% per millimeter of tumor mass. So after you have treated the patients, so it is the residua that determines the recurrence rate and then follow up of these tumors. So what they say that another strategy would be, instead of immediately stopping cabergoline therapy, why not to down titrate it? So after I achieve absence of tumor, prolactin normal, what I will do is, instead patient is on suppose 2 milligram, now I will shift him to 1 milligram and see what happens. So those patients who have recurrence of hyperprolactinemia on down titration of cabergoline therapy, this is the predictor of recurrence, and that is now the best strategy for treating prolactinoma patients. So that we follow now the down titration strategy for management of prolactinomas. So does extending duration more than 2 years reduces recurrence? The answer is yes. A lot of papers have come up. Probably they say that you can continue cabergoline therapy for further 1 more year after achieving both of the aims, that can help you in recurrence. So they say that cabergoline treatment should not be withdrawn if prolactin level increases again after cab dose tapering. Probably they will require lifelong cabergoline therapy. So last 2 slides, what is treatment resistance? Because now we have quite of data from PGI related to dopamine agonist resistance. They say that if you cannot achieve normal prolactin on maximum tolerable dose of dopamine agonist, with failure of decrease in maximum adenoma diameter by more than 30% or tumor volume by 50%, that means patient is due to agonist resistance. And mind it, this is not uncommon. You can have this kind of dopamine agonist resistance. We see almost 5 to 8% of patients, mainly in those patients who are having syndromic prolactinomas, like those are associated with maybe even this familial pituitary tumors or MEN syndromes. So maximum tolerated dose, unfortunately Endocrine Society guidelines do not mention what is maximum tolerated dose, but they say that 10 milligram of bromocriptine or 2 milligram per week of cabergoline, but I do not agree to it of this Shromo-Melmet's paper. Probably we need to hike further, maybe 5, 6, 7. Now then only you should say that this is dopamine agonist resistance tumors. I will skip this slide. There are a lot of reasons for resistance. One is decreased expression of D2 receptors. Now we do actually dotatate scans in our patients of prolactinoma to see whether the dopamine receptors are there or not, and on the basis of that we define dopamine resistance in our institute. But there may be some ER alpha expression abnormalities which can also be the cause of dopamine agonist resistance. How do we treat dopamine agonist resistance? Actually we usually either switch. This is the therapy. If bromocriptine is there, switch to cabergoline, it will lead to further normalization, or you can do surgery. But we have now a lot of experience with temozolomide and even in TKIs, and now we have experience with even ICIs, that is immune checkpoint inhibitors for dopamine agonist resistance tumors. So you can choose between all of this. It just depends upon the profile of patients what you want to do. So I'll just skip this slide, and this is again slip. This is again what I used to do in my thesis. We used to do echo in all our patients, and sometimes we just write echo. This is not right. As an endocrinologist, you should tell a cardiologist that I am looking at mitral valve or the tricuspid valve tenting area, because the tenting area is increased, and this is the early sign of regurgitation. Don't look at frank regurgitation in echoes, because the cardiologist will just put a probe and say no regurgitation is there. So look for tenting areas. This is one of the finding of paper by Annamari Kulao in New England Journal. So, risk of valvopathy is definitely real, and recurrence rate after surgery is less, and therefore Chinese are after operating all prolactinomas. What they say, dopamine agonists are good for biochemical cure rate, but surgery had a much lower recurrence rate of tumor mass, and therefore what they say that probably this can also be taken away from surgery. Last slide, is cabergoline safe in pregnancy? Yes or no? Yes? Yes? So, very few studies were there. So, we had a paper in patients with macroprolactinoma who were continued cabergoline during pregnancy, and then I did a systematic review in meta-analysis, just we published recently in Clinical Endo in 2025, and we wanted to understand the safety of prolactinomas in pregnancy, and where I could find only 12 studies all over the world with 1387 pregnancies with prolactinomas who continued cabergoline in pregnancy, and what we found out that fetal loss was higher if you continue cabergoline during pregnancy, while congenital malformation rate is not increased with cabergoline continuation in the first trimester of pregnancy. So, this is the thing, the live birth rates were almost similar whether you continue or whether you discontinue cabergoline therapy. Congenital malformation rate was also similar, it does not matter, but what we saw that probably this fetal loss was slightly more in those who were given cabergoline, who were continued cabergoline for some reason, and even preterm birth rate were not distant. So, overall we concluded in this paper, actually the editor was after my life, he said you should not demean cabergoline and it is a treatment of choice. So, we had to write cabergoline is safe in pregnancy despite some amount of more fetal loss in pregnancy. Sometimes editors also put their foot on our papers. So, thank you, this is the conclusion.
Thank you, Dr. Rastogi, for a wonderful presentation. This paucity of time, only one question I will allow.
Yes, please. Exactly. Absolutely. So, you are right. We have seen apoplexy with cabergoline also, and it is not uncommon. So, you can have 10 to 15% of patients who can have apoplexy. So, that is not unusual. Why does it occur? Why you should expect?
Shrinkage of the tumor.
So, there is a discrepancy between the
supply,
blood supply, because cabergoline acts by two mechanisms, one by apoptosis, second by decreasing angiogenesis. So, when you outstrip the blood supply for tumor, it will go apoplexy. So, you can expect that.
Then in that case, there is an uptitrate in the dose. Better to go for surgery in the hands of skillful surgeon who can, save the normal pituitary.
So, now we have modified the GCS score also for pituitary apoplexy, and I will say that there is very specific indication for doing surgery even in apoplexy. Somebody is having progressive neurological deficits or visual deficits, then only you will do surgery even in a patient who lands into emergency room with apoplexy. Because the patient I showed you, he came to us with apoplexy in 2023, but we did not operate it because we know that it was a dopamine sensitive tumor, though it recurred. So, we just gave medical therapy. So, our pituitary surgeons do not operate in almost 90% of apoplexy.
Not after occurring of apoplexy, sir. Before, like whenever you are trying to uptitrate the dose more than the recommendation,
Yes.
then is it better to go for surgery of removal of the tumor rather than going uptitration of the dose?
No.
Because at least removal of the tumor by in skillful surgeon, in hands of skillful surgeon, it can save the normal pituitary.
I'll save you. I'll give you the reason for that. No skillful surgeon can see gonadotrophs or differentiate on surgery table gonadotrophs versus corticotrophs versus thiotrophs. The best therapy would be very selective, like a gamma knife, would be dopamine agonist. You have still some chances, and you will be surprised that we have a paper in IJMR, Indian Journal of Medical Research, that what are the rate of recovery of gonadotroph access after treatment, successful treatment of prolactinoma. It's as high as 60-70%. But remember that you can have new onset hormone deficiencies also after treatment with cabergoline, like patient I showed who had empty cellar. So 20% of patients who did not had any hormone deficiency before treatment with cabergoline can develop new onset hormone deficiency. This is again because of decrease in blood supply to the pituitary. So that can happen.
Thank you.
Thank you.